Okay. Kunuz, are we ready? Kunuz, can we start?
Yes, we start.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome on board. We have at least now 1,300 logged in. I would like to welcome you on this very unique webinar on behalf of the Saudi Heart Failure Society. And I'm the moderator, Dr. Rima Bader. I'm the consultant pediatric and pediatric cardiologist. Feldman from King Faisal Specialist Hospital, Adult Congenital Heart Disease, and Dr. Huda Khalil from Al-Shumaisi Hospital. Our eminent speakers, we have two very eminent speakers talking about heart failure today, one from the pediatric point of view and the other from the adult congenital point of view. As we know that children never grow up in heart disease. We have to be after them all the time until they grow from 0 till 50, they are congenital. So we need to talk about heart failure starting from pediatrics. I didn't say starting from fetal, and then we go into adult. So if you'd allow me to introduce the first speaker is Dr. Paul Cantor. Dr. Paul Cantor is head of cardiology in Los Angeles, and he has lots of publications and one of the world eminent figures in heart failure in children, and he wrote the guidelines in 2013 for heart failure diagnosis and management for the Canadian Cardiovascular Society. Welcome on board, Dr. Cantor. And if you would love to, we'd love to have you on board. And if you have to add anything in the introduction about your career or about your interest, that'll be very great. Thank you.
I'm very glad to be here. Thank you to the organizers for this kind invitation. I think it's a
Dr.
unique
Cantor?
time. Yes, can you hear me? I'm hoping you can hear me. Thank you for the kind invitation. I'm very pleased to be here, and I thank the organizers for this kind invitation, and to all of those of you who have dialed in or logged in. Thank you for being here today. This is an important time of history for the world. And I think as physicians and as pediatric practitioners, we have a unique contribution to make. And as adult congenital specialists, we also have something very important to share. And I'm hoping today will be a great educational event. So I look forward to talking with you.
Thank you. So would you love to start?
Certainly. I've been asked to speak to everyone today. Could I just have a thumbs up from my co-moderators if you can see the screen that I'm sharing?
Not yet.
Let me try and get it right here. Pardon me. So you should be able to see a title slide now.
Yes.
Hopefully. Good. My topic today is to deal with heart failure and congenital heart disease, and also to give you a sense of how we look at this in children, and to give a perspective on what we might encounter in patients with COVID and how to differentiate conditions where the heart is compromised due to systemic inflammatory conditions like COVID, or due to congenital heart disease, which is much more well described and has somewhat different presentation features. I will disclose that I am associated with Novartis with a small role in regards to a clinical trial involving neprilysin inhibition with Valsartan-Sacubitril, and have also been engaged with the trialing of ivabradine as a heart failure drug. Our key learning objectives should be, firstly, pathophysiology of heart failure and congenital heart disease as it appears in children, the outcomes, so we need to know something of natural history, which Dr. Ari Cedars is going to probably speak more about than I do, because this becomes a huge problem in adult patients. And some of the clinical features and therapies that we can bring to bear that might help, not definitively will help, but might help. We should all recognize that for children with congenital heart disease, there are some high-risk conditions that tend to lead directly to a more significant prolonged outcome of dysfunction. These are patients who have a systemic right ventricle, such as congenitally corrected transposition, patients who've had an atrial switch operation for various different reasons, either because their coronary arteries were considered to be inoperable or because they came from an era or a region in the world where the best survival was likely to be through an atrial switch with transposition of the great arteries. Of course, Fallot's tetralogy has been with us and undergoing surgery now for nearly 70 years. And so we should be well accustomed to seeing patients with this condition, but nonetheless, it can still present challenges in some patients, even during childhood. Obviously, single ventricle palliation is the biggest concern that pediatric cardiologists face in regards to consistent progression towards heart failure and differentiating Fontan circulation dysfunction from mechanical heart failure. And then other complex lesions that I think are becoming more evident in some programs where late attempts at septating what was thought to be a single ventricle heart is undertaken, and patients who present with valvular abnormalities in whom an innovative type of repair, such as we see with the cone repair in Epstein's anomaly, can be undertaken in teenagers, and sometimes the effects are not as good as we think. Going back to what diagnoses are more likely, this is a series done at an outpatient facility where about 300 or so patients were seen in sequence, and it was found that the likelihood of heart failure as a presenting symptom, in this case based mostly on natriuretic peptide measures rather than AHA or NYHA status, was seen to be most common in patients with single ventricle tetralogy of Fallot and transposition of the great arteries who have had a mustard procedure. And bear in mind, the actual frequency starts to increase in the late teenage years rather than earlier on. The Dutch group did a very nice meta-analysis of over 300 series, which makes the point that we have a problem with fragmentation of registries, where we have registries that take in mostly children and some that do mostly adults, and the overlap is a problem. And what we really need is a consistent birth to later adult age registry to cater for the incidence of heart failure. But to mention here that about 50% of patients in this registry presenting during the childhood years, and these are patients who underwent an atrial switch for transposition of the great arteries, were considered to have heart failure. So in fact, it can occur and does occur in children with congenital heart disease before they reach adulthood sometimes. We all know that congenitally corrected transposition, particularly if it's associated with a lesion, obviously the most common one being a VSD, but of course, abnormalities of the systemic tricuspid valve is commonly associated with symptoms by the time patients reach middle adult years. And not infrequently, these patients will have biventricular disease as well. Atrial switch concerns are well known, and we'll hear more about this, I'm sure, from my colleagues who are more involved in these patients than I am nowadays. But effectively, even with a consistent follow-up over a period of years, what we tend to see is progressive decrease in survival without reoperation, heart failure, or arrhythmias, and a class shift from New York Heart Association class 1 early on to mostly class 2 or 3 later on. And this is a sequential series of patients seen at 2 intervals. Tetralogy of Fallot is not commonly recognized to cause left ventricular heart failure, but it does. And it does so in certain circumstances, perhaps related to severe RV dysfunction, but possibly also related to occasional patients who have left bundle branch block and dysynchrony. And so this needs to be looked out for as well. I wanted to make the point that for children with congenital heart disease, there is a very prolonged latency phase with heart failure. Apologies for this blurred slide. But what I'm trying to show you is there's a very long pre-heart failure and asymptomatic heart failure stage, where we classify patients as heart failure stage A or B, and long before they develop symptoms, are they already showing some changes in ejection fraction and cardiac index if we catheterize them or we measure non-invasive cardiac output. And this is a time scale of years, and actually this is the time where intervention is most necessary and most required. Let me get rid of that. Conventional wisdom suggests that the way heart failure develops in children with congenital heart disease is that they have an underlying primary cause, in this case, usually a systemic right ventricle, that there is a remodeling stimulus as well as that, and typically that's a volume or pressure load, and so we think of tricuspid regurgitation as being one of the most common ones in our single ventricle population. And then, of course, the neurohormonal second messenger, typically norepinephrine, is the one most cited, but angiotensin, aldosterone, and others are equally important here. The mechanistic overview that brings us to bear then is that the underlying primary cause is a congenital defect that has a structural abnormality resulting in volume or pressure overload combined with the contribution of a surgeon that's trying to fix it, leading to an ischemia and reperfusion injury. And sometimes, perhaps, we don't really know much about this, but the underlying genetic material from which the patient and the heart are constructed may also predispose them. And with this, a chronic pressure and volume loading and mechanico-electrical dysfunction results in neuroendocrine activation, changes in the matrix, second messengers via cytokines, and eventual heart failure. The neurohormonal factors have been identified as being very important. This from the group in London. Both renin and aldosterone are clearly very elevated in patients consistent with their New York Heart class, and these are patients with repaired congenital heart disease, but also endothelin-1 and norepinephrine. And so we think of this probably as a chemical soup of different neurohormonal markers that are elevated in these patients and contribute to them progressing to heart failure. I think we should also bear in mind that it's not all just systolic disease. Systolic heart failure is easy to identify, typically. We have a large heart with a low ejection fraction, and we experience this very commonly in repaired congenital heart abnormalities. But what about diastolic heart failure? Those patients that have normal or small chamber size that have been subject to significant fibrosis. This is much more common in pressure load situations and in patients who've had multiple sternotomies with constraint of their mediastinum, in whom a single ventricle physiology no longer has a low end diastolic pressure. And as they get older, this gets worse. And so we need to bear that in mind as well when we confront patients who have decreased renal function or congestion symptoms, that in fact the ejection fraction is likely to be normal or difficult to demonstrate that it is in fact out of keeping with their functional status. And then finally, I'd like to talk a little bit about the Fontan circulation and its contribution to heart failure and congenital heart disease. In their own words of Fontana and Krautzer, it is evident and was evident to them that a progressive decline in functional status will appear in many of these procedure survivors. They will develop heart failure by virtue of arrhythmias, thromboembolism, protein-losing enteropathy, plastic bronchitis, unexplained sudden deaths, and hepatic failure. This has all been known for more than 25 years. The reality is that these problems will occur as patients live to late follow-up. The pathophysiology of this, as many of you already know, requires us to first recognize that there is a distinction between Fontan circulatory failure, which is probably the majority of these patients by virtue of venous hypertension, lymphatic problems, enteric liver and kidney dysfunction, and proliferation of multiple arterial collaterals throughout their lungs and in other organs, leading to pulmonary vascular changes and hypoxemia. And much less frequently do we actually see overt Fontan pump failure in a way that we can measure it easily. This is often associated with AV valve dysfunction and diastolic dysfunction, and only occasionally with systolic dysfunction. So this really represents a very small part of the problem of Fontan failure as we see it in children and adolescents. Probably, I would say, likely in young adults too. We're worried about venous hypertension as being a common pathway for all of this. And as you all know, it is obligatory and universal in patients with a Fontan circulation, that it's directly related to the pulmonary vascular resistance and inversely related to pulmonary flow, associated very likely with multiple thrombosis episodes, only some of which do we recognize. And we only identify this technically at a mean PA pressure of 15 millimeters mercury, but it exists effectively at anything over 8 millimeters mercury mean PA pressure in children. And so we have a very wide range of what we consider to be at risk. But frankly, I would say that any one of those patients is on the progression slope towards venous hypertension and eventual Fontan dysfunction and possibly circulation failure. We know also that lymphatic failure and effusions are a manifestation of maladaptive and progressive disease of the lymphatic system. It is multi-compartmental, it's associated with lymphopenia and immunoglobulin deficits, and results in effusions that compromise organ perfusion and venous flow. And we have several tools by which we can assess this. What we don't recognize as well is the enteric liver and kidney abnormalities that exist in these patients. We know that protein-losing enteropathy in the context of Fontan heart failure or Fontan circulation failure is very common, and it ranges in severity. It is a traditional transplant indication for children and adolescents, but it's also associated with growth failure, diarrhea, bloating, and very, very unpleasant quality of life for these patients. Liver dysfunction is a very important feature of this. I will not discuss that much today. Kidney dysfunction is also a result of prior surgical experiences, a lot of diuretic use, and sometimes angiotensin converting enzyme inhibitor overuse. And again, a lot of assessment tools that we have available to us to identify this disease. We should also acknowledge the fact that there's venous and arterial proliferation as a result of surgical anatomy, pressure abnormalities, thrombus, and hypoxemia, and that this likely begins long before the Fontan and results in severe problems in certain specific anatomies. Particularly, we focus on AV malformations in patients who have a long-standing Glenn or Kawashima palliation prior to completion of their Fontan. And again, we have several evaluation tools available to us. I'm not going to speak too much about pulmonary vascular changes and hypoxemia, but we do know now that there's promising data for the phosphodiesterase 5 inhibitors to be used for these patients. And what I'm seeing in my practice is that more and more patients are being put on these without clear evidence that it actually benefits them, other than the most recent fuel study, which showed a submaximal increase in oxygen consumption. The possible risk factors, therefore, for developing all of this can be listed here, and I think it's worth noting all of these because you'll see these in many of your patients without identifying them as having heart failure. You may well identify ventricular dysfunction. You certainly will see them with long-standing volume overload. Many of them will have an inadequate systemic ventricle. They may have cardiomyopathy underlying this or myocardial fibrosis. Some of them have unfortunately had a PA band, which has resulted in thickening of that ventricle. Some of them will have a history of prior or current systemic outflow tract or arch obstruction, and all of these can be addressed. Some of them have had inadequate myocardial protection. Many of them will have arrhythmias, and some or moderate amounts will have AV valve incompetence. Pulmonary vascular malformations and collateralization are also common. So all of these, if you take these together, constitute a plethora of risk factors for heart failure in these patients and to be looked out for and attended to in great detail if possible. Let's move on from the hepatic changes, since there are many others who can talk about this more than I, but just to say that they are common, ranging from nodular proliferation, hepatomegaly, and occasionally tumor development. The problem of therapy, however, is one that has reached a point of polypharmacy, where you can see here over the decades and centuries, we've added more and more medications. Most recently now, the funny current inhibitor, ivabradine, and now Valsartan-Sacubitril into the mix for possible treatments for heart failure by ERA. In heart failure due to cardiomyopathy, we tend to take a stepwise approach of introducing these drugs, starting usually with pulse diuretic and ACE inhibitor therapy, and then beta blockers. And now more recently, we add aldosterone antagonists to all patients. And we only use inpatient or vasodilator and vasoactive therapy in patients who have severe or intractable symptoms. It's hard to know whether this really applies to heart failure and congenital heart disease. We'll talk about that in a few minutes and propose a different algorithm for using drugs. But simply to understand where this came from, all of this is based on adult data, and very little of it is based on pediatric data. And so we have the original Solvit trial of Enalapril versus placebo that showed a substantial reduction in mortality. At that era, we were dealing with 40% mortality. As we go on, you'll find it decreases. Rails in 1999 introduced the concept that additive spironolactone would be beneficial for mortality. Copernicus in 2001 was the landmark trial of carvedilol, still perhaps the most used beta blocker in adults and pediatrics with heart failure. And now we're seeing that substantial reductions occur in mortality. Emphasis re-emphasized, if I may, the role of a aldosterone antagonist, in this case eplerenone, for the same purpose with a substantial reduction in mortality. And then Paradigm, the most recent mega trial that demonstrated the use of Valsartan-Sacubitril in these patients. And now what we see is that the control group mortality is down to 20% from 40%, so effectively halved in the period of 2 decades, and a much smaller absolute reduction in mortality using this drug. But what about children? Recently, and perhaps destined for reporting sometime in the next year or two, a trial of Valsartan-Sacubitril was launched in children, and I'm pleased to say does include children with congenital heart abnormalities, as long as it's biventricular. The design of the trial included several doses and several different age ranges, so we will be able to hopefully deal with these age ranges specifically, because we believe that the disease is different at different ages. These are the data that emphasize or that portray the value of ivabradine, which is not commonly used in the United States, but is commonly used in Europe and other places, showing its benefit for heart failure-related hospitalization and mortality in adults. And indeed, there was a study of this drug in children with dilated cardiomyopathy, but not with congenital heart disease. The study did show a benefit of ejection fraction reduction, and of course, its primary endpoint was a reduction in heart rate, which is thought to be a important indicator of survival in heart failure overall. Ivabradine does have an indication for use, and some other drugs and trials that have not yet reached the point where they can be used. I just refer to serelaxin, which unfortunately did not receive an FDA indication, and the omecamtiv mecarbil cardiac myosin activator series of studies in adults, which has not yet reached children, and is still to be determined how it will be usable in patients who have congenital heart failure, congenital heart disease related heart failure. The problem with all of this is that there's very little coexisting congenital heart disease in most of these trials, and so it's very hard to extrapolate that any of these will be useful to patients who have heart failure of a right ventricle or systemic right ventricle. These are the indications for use in pediatric heart failure that I've listed here. Effectively, we use diuretics and milrinone in acute decompensated failure. We use ACE, beta blocker, mineralocorticoid antagonists as class 1 indications, and ivabradine and digoxin at present as class 2A. And recently, Valsartan-Sacubitril received an FDA approval for use off-label. Finally, I'd like to put forward a different paradigm that really should probably apply for patients with congenital heart disease and heart failure, where you start from the bottom up. And this was published by these authors in a very nice overview of whether or not heart failure medications work in children with congenital heart disease and heart failure. And what they show is that really what we should start with is structural reintervention to improve valvular and vascular residual lesions, and then consider device therapy and in particular cardiac resynchronization. And only finally should we really be relying on neurohormonal modulation. In fact, it does play a role, but probably mainly in symptom relief rather than changing the eventual outcome of these patients. So in fact, it inverts the concept that you start with medical therapy. And this is an interesting concept that I think should be debated. My final comments will be relating to COVID-19 in pediatric patients. I should say that there is no published experience in pediatric congenital heart disease with COVID at this point. There are numerous cases of the multi-system inflammatory syndrome in childhood, which is characterized by inflammation and vasculitis, fluid-resistant shock, which is notable in that when patients are loaded with fluid, they tend to get worse, and they don't necessarily improve their blood pressure at all. They have transient myocardial dysfunction and massively elevated NT-proBNP, D-dimer, and other markers. A recent publication from our colleagues in Paris has given us some insight into what these patients look like with their lab profile. And what we see is very high markers, as indicated here, of various different inflammatory and heart failure biomarkers. The patient profile, interestingly, tends to have a median age of around about 10. There seems to be an equal distribution between males and females. There are, in our experience locally, we are seeing patients who have a high body mass index as being a significant risk factor for hospitalization in this situation, and a broad range of symptoms which overlaps with both inflammatory disease and occasionally with conventional heart failure if we look at gastrointestinal distress, respiratory distress, and so on. And so really there is no easy way of separating out the diagnosis of COVID-related transient myocardial dysfunction from our conventional understanding of inflammatory cardiomyopathy, except to say that these hearts are rarely dilated. They typically present with only mild dilation and decreased ejection fraction. And they also tend to get better. And so the median recovery time here was 2 days with a range of 2 to 5 days. And these are patients that tend to be treated with corticosteroids, with occasional support with milrinone and pressors because of hypotension, and a quite dramatic profile of recovery rather than progressive grumbling, inflammation, and dysfunction. So in conclusion, heart failure and congenital heart disease, I would say that the preclinical phase is prolonged and occupies most of childhood. That deteriorating systemic ventricular function is very, very important and parallels New York Heart Association status, but tends to precede it by several years sometimes. Empirically, we see that this is more common in volume and pressure-loaded hearts who have not yet had complete relief of one or other of their lesions, and that usually is the first port of call to try to address their problems. We do see neurohormonal activation accompanying this, but not at the scale that we see it in cardiomyopathy or inflammatory disease such as COVID-19. And certain lesions are at much higher risk. Patients with congenital heart disease are markedly underrepresented in drug trials, with the possible exception being the Valsartan-Sacubitril trial, but only including biventricular physiology. And the employment of drug therapy is probably not the first or most valuable approach to these patients, but best to get them catheterized, determine their hemodynamics, and then decide if there's any structural or rhythm-related intervention that can serve them best first before considering elevating drug therapy for them. I thank you for your time. I'm just over 30 minutes here, and so I think I should hand back to the panelists, and I believe we'll have time for questions at a later date, so I will stop sharing.
And for the sake of time, we can go for our next eminent speaker. And I would ask Dr. Veltman to introduce Dr. Cedars, please.
Sure. Well, firstly, welcome everyone to this evening's webinar. I can see there's over 2,000 of you online, and I please accept our thanks for spending the time on this webinar. And Paul, thanks for an excellent overview of pediatric heart failure and also how it pertains to COVID-19. So it gives me really great pleasure to introduce Dr. Ari Cedars. Ari is both a friend and a colleague, and we tried to steal him in Cincinnati, but Ari clearly had his eyes on greater things. Ari has enormous academic integrity, as you will see, and also Ari has a very wide clinical interest, and he, for example, developed one of the very few ECHD patient-reported outcomes tools, and has actually just recently published that. It's an absolutely excellent tool. And Ari also has an enormous interest in heart failure and advanced therapies, and is a very good speaker and frequent speaker on the subject. But what impressed me probably most about Ari amongst his academic integrities is interest in megadata, which really is quite impressive that he can process all this stuff. So Ari, I really look forward to what you've got to say about heart failure and congenital heart disease, in adults particularly, and then also in the era of COVID-19 disease.
Thanks so much, Grushin, for the kind introduction, and thanks to you all for the opportunity to talk with you today. I will be speaking about heart failure in adult congenital heart disease and what we know about it. It's not going to forward my slides. Let me see if I can figure out. We'll use these controls then. These are my disclosures. I have worked as a consultant for Medtronic and Syncardia, and I'm a member of the Action Learning Network, which is sponsored by multiple device companies as well as some charitable societies. And we can discuss more about the Action Learning Network and its role in pediatric heart failure in particular at the end of this, if that's an interest. So I'll be speaking first about the epidemiology of heart failure and congenital heart disease in adults. You've heard some of that from Dr. Cantor already. And then I'll touch on some of the challenges related to heart failure and its management, specifically in adult congenital heart disease. We'll then move on to transplant and mechanical circulatory support in adult congenital heart disease. And then I'll conclude by discussing briefly the little that we know about COVID-19 and the way in which it interacts with adult congenital heart disease. So adult congenital heart disease has become a big deal because of demographics like this. This is actually data from Canada, but it's largely reflected in the majority of the world where modern surgical technique is available. And what we see here is that at least since 2000 in Canada, and this is probably the same in the United States and Europe, the number of adults with congenital heart disease has exceeded the number of children. Adults here are depicted in red and children in purple. And this goes for all congenital lesions, as indicated in the top graph, as well as for the most complex forms of congenital heart disease, indicated at bottom. And although we are doing a great job of allowing children born with complex defects to survive into adulthood, that doesn't mean that their life expectancy is completely normal. And this is the burden on us as adult congenital providers to try and solve this problem in this unique group of patients. This is data from the Netherlands, where it's depicted that compared to the general Dutch population, which is indicated here in the hashed black line, while those with the most simple forms of congenital heart disease, as indicated in green, have a fairly comparable life expectancy, those with either moderate, here indicated in blue, or severe forms of congenital heart disease, that indicated in red, have a significantly compromised life expectancy. And one of the major reasons for this compromised life expectancy is the development of heart failure. And this same graphic has already been shown by Dr. Cantor, and I guess it means that it's a good one. And so I am showing it again. This is depicting the probability of developing heart failure across the lifespan among individuals with various congenital cardiac lesions. And while the growth in prevalence and the date at which heart failure takes place is earlier among patients with more complex forms of congenital heart disease, it really begins to develop even in people with more simple forms of congenital heart disease. Not surprisingly, therefore, since the numbers of adults with congenital heart disease are growing in the United States, and since incident heart failure becomes more common as congenital heart disease patients age, the numbers of heart failure hospitalizations in the United States have increased over time. And it's not just heart failure one time. Adults with congenital heart disease who present once with heart failure are very likely to come again within 1 year. This shows in the top graph that among individuals with congenital heart disease who are hospitalized multiple times in 1 year for any indication, the most common diagnosis at index hospitalization is congestive heart failure. And then at repeat hospitalization, the most common diagnosis is congestive heart failure. And this largely mirrors what we see in the non-congenital heart failure population, who are prone to repeated hospitalizations. And in fact, rehospitalization is one of the metrics by which quality of care is assessed in the healthcare systems in the United States. Hospitalization for heart failure is not a benign thing in congenital heart disease patients. This is again data from the Netherlands, and you can see that once you've been hospitalized once with heart failure, the probability of dying within the ensuing 12 months is up to 20% for congenital heart disease patients. So this is kind of a frightening statistic. Somebody comes in with heart failure once, how are we going to intervene in this scenario to prevent further progression? Because ultimately what happens is patients with congenital heart disease who come in with heart failure, they die. This is data from the Netherlands that shows that the most common cause for mortality in adults with congenital heart disease is congestive heart failure. And this is a nearly superimposable pie chart that comes from the Congenital Heart Disease Database in Germany, showing that also congenital heart failure is the most common cause of mortality. And so we're getting around to the question that Dr. Cantor addressed, which is, so what are we going to do? What do we do with these patients when they come in? And this is a huge problem for the reasons that Dr. Cantor touched upon, which is that we don't really know how to best manage these patients. There is little to no evidence that modern guideline-directed medical therapy, neurohumoral modulation, is of any efficacy in this population. And the few small trials that have been done have been largely equivocal in their results. There are a lot of reasons for this. There are a lot of reasons for the challenges that we experience in proving that pharmacologic therapy may be of benefit in heart failure with adult congenital heart disease. The first of which is that agreeing upon a definition of congestive heart failure in adult congenital heart disease is not entirely straightforward. Definitions go all the way from they all have heart failure to very specific combinations of exercise capacity and serologic hormones to, well, if they've been admitted once with heart failure, then that's how you define congestive heart failure in adult congenital heart disease. On top of that, you can say, let's say that, okay, we can probably all agree that we know when we see adult congenital heart disease with heart failure, we know what it looks like. And what it looks like is somebody whose heart has a limited capacity to augment output in times of need. But even that definition is fraught with difficulty because depending on what lesion you're born with, your expected exercise capacity may be quite different. This is data from the Royal Brompton in England, and where they have separated healthy ambulatory patients based upon their exercise capacity. And while you can see that those with either fairly good anatomic forms of repair or more simple forms of congenital heart disease have near normal exercise capacity compared to the general population, and what these numbers indicate is what percentile they would be compared to normal. More complex forms of congenital heart disease have 50% the expected exercise capacity of normal unaffected peers who are age and gender matched. And so exercise capacity, or the capacity of the heart to augment output in times of need, is not going to be an adequate definition. Add to that the heterogeneity of adult congenital heart disease in general. You just take, for example, Tetralogy of Fallot. A TET is not a TET is not a TET. You have Tetralogy of Fallot with absent pulmonary valve, with pulmonary atresia. You have pink TETs, you have blue TETs. Add to that the layer of complexity imposed by the creativity of the surgeon who performed the initial repair and the way in which they performed that repair, and the downstream sequela that those variables may have on somebody's probability of developing heart failure. And you begin to understand why performing a reasonable clinical trial in congenital heart disease is remarkably complex. You can't define a sufficiently homogeneous population to be able to study. You have a small group of people, and they're incredibly heterogeneous, and it's very likely that there's heterogeneity of treatment effect. And for that reason, although it is almost certain that neurohumoral modulation is of benefit in certain individuals with congenital heart disease presenting with heart failure, teasing out which individuals are likely to respond from those that are not is beyond the data that we have available at the current time. And for that reason, when the intelligentsia of the European and American heart failure communities came together in 2016 to try and define what they would recommend as treatment strategies for adults with congenital heart disease presenting with heart failure, what they came up with is almost identical to what Dr. Cantor already showed you, that there is essentially no proven medical therapy for heart failure in adult congenital heart disease. Probably individuals who have 2 ventricles and a systemic morphologic left ventricle, modern neurohumoral modulation is efficacious. And this should in no way be a disincentive to employing it, because it probably is helpful, but recognize that there's no data to support that. In individuals with 2 ventricles and a systemic morphologic right ventricle, although it's probably a group of people that will move through the system and then will no longer be present. It's kind of a transient condition. But at this point, there are many of them in adult practices. We don't know if any of this is going to be beneficial in those patients. And people with a single ventricle, forget about it. There's basically no evidence that any of this is beneficial in those patients at all. And what we really need to focus on is anatomy and arrhythmia. We need to identify defective anatomy or inefficient physiology and correct those problems to maximize efficiency. And then we need to identify potentially undetected arrhythmia and fix those problems. So, in the absence of any therapy, adult congenital heart disease patients progress through the heart failure stages and end up at transplant, and therefore numbers of individuals with congenital heart disease being referred for transplantation and being transplanted are growing in the United States. This separates the numbers by whether or not they are listed and transplanted at adult centers in blue or pediatric centers in red. But the reason I'm showing the graphic is to demonstrate that the numbers are increasing, which should come as no surprise as the size of the population increases and given the increased prevalence of heart failure among congenital heart disease patients as they age. The problem then, after referral for transplant, is getting them successfully to transplant. Adult congenital patients actually do quite well after transplant, but getting them there is tricky because they have a prolonged waiting list time. This is data that we derived from the scientific, the Scientific Registry for Transplant Recipients. Is basically a scientific registry that collects UNOS data and marries it with death data from the United States. And you can see that adult congenital heart disease patients wait substantially longer for transplant after being listed for transplant. And even the sickest of adult congenital heart disease patients, those who are listed status 1A, urgent listing for transplant, have a longer wait list time. And this is problematic because, as you can see in this data from the Brigham and Women's Hospital, individuals with congenital heart disease listed 1A have a significantly greater probability of dying or delisting due to clinical worsening, which when you're listed for transplant is the equivalent of dying, when you're listed status 1A. And to walk you through this graph, congenital heart disease patients are listed as solid lines, non-congenital are the dashed lines. 1A listed patients are blue, 1B are red, and 2 are gray. And you can see that this high-risk group of people, listed 1A, have a much higher probability of dying or delisting due to clinical worsening if they have congenital heart disease. Moreover, after transplantation, adult congenital heart disease patients have a liability, particularly in the first 30 days, in the peri-transplant period, the perioperative period. Now, while there are multiple variables likely contributing to this increased liability, and those include complex anatomy, the fact that the operation likely takes longer, and so as the graft organ sits aside while the surgeon is doing the surgery, there's a greater probability of primary graft dysfunction. It also, in part, is attributable to the fact that if you take a sick patient to the OR, they're more likely to be sick after they come out of the OR. And somebody who is listed 1A is in urgent need of transplant and has waited a prolonged period of time to get that transplant is therefore more likely to be sicker. And I think in recognition of this, listing status was recently reassessed in the United States, giving a favored status to individuals with congenital heart disease. Some would argue, and I'm among this group, that they probably should be shifted even further, giving an even further advantage, but we have to wait for the data to bear that out. But given the data that we have available now, there is a technology that has been developed which allows patients to better survive to transplantation and may improve post-transplant outcomes in the most sick individuals, and that's mechanical circulatory support. The problem is it's barely ever used in congenital heart disease patients. This is somewhat older data, but I think it's really not changed that much. With the advent of ventricular assist device technology, which is really what's predominantly used in adult patients, you can see that it was rapidly adopted as a bridge to transplant in the non-congenital population. However, it remains barely ever used in the adult congenital population, and it's understandable because really these devices are purpose designed for people with normal two-ventricle anatomy and a morphologic left ventricle, and it's unclear whether or not it actually would be of benefit or if you would just be exposing people to an unnecessary surgical procedure to use it in adult congenital patients. And so I undertook an investigation using the INTERMAX database. And for those of you who are unaware of what that is, it's basically an obligatory database for post-marketing monitoring of mechanical circulatory support devices in the United States. And we looked at adult congenital patients and age, gender, and risk factor matched, propensity matched, non-adult congenital patients and their outcomes after mechanical circulatory support implant. And what you see is results that are not dissimilar to those you see in transplant, that there appears to be an upfront liability in the individuals with adult congenital heart disease. However, if you censor all patients who die in the first 5 months after implant, the curves are nearly superimposable, suggesting two things. Number one, that there probably is some specific expertise that's required for surgeons who are implanting mechanical circulatory support devices in adult congenital heart disease patients or individuals who have unusual anatomy. And second, the same thing that we had mentioned in the transplant data, that if you wait too long, and I think that in a lot of cases, mechanical circulatory support in adult congenital heart disease patients is employed kind of as a Hail Mary pass, which that means when somebody who's catastrophically failing, it's something that's employed as in a last-ditch rescue effort to allow for a potentially good outcome. And I think that if it were employed in an earlier time and in centers with expertise, these numbers might be better. Now, the astute amongst you may also notice that there seems to be a second little dip here around 12 months where there's higher mortality in adult congenital patients. And I would argue that a part of the reason for that is because adult congenital patients are waiting longer for transplant and dying while they're waiting. So although this is competing outcomes graphs, mortality is indicated in red, device-supported patients indicated in green, transplanted patients indicated in blue. And you can see that the number of transplanted patients is substantially higher in non-ACHD patients indicated in the right-sided graph compared to the ACHD patients indicated in the left-sided graph. And while there is a difference in mortality, there still are more patients with congenital heart disease supported on device. And the longer you're on a device, the more likely you are to have a bad outcome while supported on that device. And so it becomes a self-fulfilling prophecy. That being said, I do believe that the data are now adequate to support using mechanical circulatory support in adult congenital heart disease patients awaiting transplant if it's appropriate, and that with further use, that outcomes will likely improve. Moving on then to COVID-19. I am not an infectious disease specialist. I'm not going to pretend to know about the epidemiology of congenital heart disease. I am a cardiologist. I'm not going to make the mistake that Mandeep Mehra made trying to write something about therapy for a virus when I'm a cardiologist. I'm going to just be talking about the cardiac impacts of COVID-19. Why do we even care? Well, because early Chinese data indicated that individuals who had a history of hypertension or a history of vascular disease, either coronary vascular disease, cerebral vascular disease, had a higher risk of death after infection with COVID-19. Furthermore, they identified that elevations in troponin and in beta natriuretic peptide were associated with adverse outcomes after infection with COVID-19. Now, one of the early hypotheses as to why this might be the case is the way that the virus infects people. You see, the virus uses the angiotensin converting enzyme 2 receptor, which is on the surface of alveolar epithelial cells, vascular endothelial cells, as well as myocardial cells, to gain entry into cells and proliferate. And it was thought, because we know that both ACE inhibitors and angiotensin receptor blockers increase the density of ACE2 receptors on cell surfaces, that it was permissive. It was allowing more virus to get into the cell, denser infection rate, and that therefore it was a liability. And that's the reason why people were dying. But there's a counter argument. And that counter argument is that angiotensin 2 is responsible for catalyzing the reaction for conversion of, ACE2 is responsible for catalyzing the conversion of angiotensin 2 to angiotensin 1,7, which is beneficial. Beneficial not only because it's a vasodilator, but also because, at least in mouse models of fibrotic injury, specific bleomycin injury, it prevents pulmonary fibrosis. And so, if somebody has previously been on an ACE inhibitor or angiotensin receptor blocker, it actually will be protective against the potential fibrotic response that is a long-term sequela of this very aggressive inflammatory condition that occurs post-COVID infection, and therefore maybe even protective. And I can tell you that there's a publication out of Denmark that I got the alert today on my computer, and it came out in JAMA Cardiology, where they had 2,400 some patients. I think no, it was 4,000 something patients. It showed that those with ACE inhibitors had no difference in outcomes compared to those without. And so probably it's somewhere in between these two. So if we don't think that ACE2 is responsible for direct myocardial damage in COVID infection, what is? Well, we know that there are kind of two stages of this COVID infection. There's the initial infection stage, and then there's this post-inflammatory stage, which occurs, about 10 days to 2 weeks after the initial infection. And that seems to be really where the money is in terms of cardiac damage. And there's a cytokine storm that occurs during this later inflammatory stage. And we know that inflammatory mediators are toxic to the heart, whether they're TNF-alpha or IL-6. And so direct cytokine-mediated myocardial damage is definitely one of the reasons why we're seeing these correlations between troponin release, BNP, and outcomes in COVID infection. There's possibly direct myocardial infection with COVID. This has been shown in vitro. I think there's only one autopsy study which has shown evidence of virions in myocardial cells post-mortem. But it's thought that this probably plays a lesser role. We do know that people who have COVID infection have profound hypoxemia at times. And in an individual who has already either epicardial vascular disease or who is chronically cyanotic at baseline, there's decreased reserve to handle the hypoxic stress compared to the general population. And that may be a liability in the adult congenital population as well. And then finally, we know that in COVID infection, as well as in just general systemic inflammatory response, there are microemboli which develop that diffusely clot off small capillary beds and can lead to microscopic damage, including in the myocardium. Why do we think this may be of damage or these may be relevant in congenital heart disease? Well, we don't know specifically the interaction. I'm going to show you, there's actually one paper I managed to find, just was published last weekend from Italy, but we really don't know how this is going to interact with adult congenital heart disease. Hypothetically, there's increased risk in individuals who are cyanotic. Like I said, if you have profound hypoxia on top of underlying cyanosis, you're just that much closer to decompensation. Individuals with shunts probably are at increased risk as a result of transit of microemboli. Pulmonary hypertensive patients, obviously, due to alveolar hypoxia, may experience a worsening of their pulmonary hypertension. And then anybody with cardiomyopathy to begin with, the stressors of hypoxemia and the overall systemic inflammatory response are likely a liability. And this is the data I was alluding to. It's very limited. It's 76 total patients, 4 of whom were actually pediatric, 72 are adults. It's a wide variety of lesions. And what you can see is actually things don't look so scary. Now, I'm not saying that we should become lackadaisical, but it does appear that, like we have reported in the general population, younger individuals, the majority of these individuals were younger, who develop COVID infection probably have a reasonable prognosis. Heart failure is the most common sequela of COVID infection in this Italian group, although there are other sequelae as well. Again, the numbers very small, but most reassuringly, the vast majority of individuals who either were suspected or had confirmed COVID infection had only a mild respiratory syndrome. Is there some impact of the drugs? I thought I'd touch on this. We don't know if any of these drugs are going to be of benefit, but in case any of them are, do we anticipate that any of them might be toxic to the myocardium directly? Remdesivir, for those of you who don't know, it's being studied right now. It was used in Ebola. It may be efficacious in vitro. It's efficacious in treating COVID-19 infection. No likely cardiac side effects. Hydroxychloroquine, I think data is now showing it's probably not efficacious, but it does have QT prolonging side effects. And therefore, if you are going to use it, it should be used with caution. Additional caution if you're using it with macrolide antibiotics, which I think was the initial manner in which it was proposed to be used. And then ritonavir, leponavir, which is it's actually anti-HIV drug, antiretroviral drug, which is also being studied for therapy in COVID-19, may also have QT prolonging effects. Again, just for future reference, none of these have been proven beneficial yet. And so to conclude, ACHD-related heart failure is increasing, probably because the adult congenital heart disease population is increasing in size and heart failure incidence or prevalence increases with age. There are no proven medical therapies. Thankfully, heart transplant is a good option in adult congenital heart disease patients, and mechanical circulatory support is a good option. However, we really need to enforce early referral for consideration for advanced cardiac care, and that these procedures be done at specialized centers where their surgical and perioperative management is familiar. And that COVID-19 in general should probably be avoided by individuals who have underlying heart disease, whether it's acquired or congenital, because we really just don't know how COVID-19 is going to interact with the underlying heart disease at the current time. And it's best to in the absence of knowledge, to avoid the liability. And with that, I will conclude and open up for questions.
Thank you very, very much for such a beautiful talk, Ari, and also thank you very much, Paul. I would love to continue, but for the sake of time, we're going to go for questions from the participants here. And the first question go to Dr. Cantor, saying that as a pediatric cardiologist or in heart failure, just give us a scenario of what treatment you're going to take to give a patient just normal for heart failure, because you said I'll use this, I'll use that. So what is your standard and how would you escalate therapy? Just very simple.
Very simply, if your patient has symptoms, you should admit them to hospital. If they don't have symptoms, you might be able to manage as an outpatient. Your first step is to decongest them with diuretics, and following that, you would start them on an ACE inhibitor if they have an ejection fraction of less than 50%. Beta blockers tend to be used, although the evidence is not as good. I tend to use them when a patient has an EF of less than 40%, and a spironolactone or a eplerenone, an aldosterone antagonist, should be added to all those who remain with low ejection fraction and or symptoms with initial therapy.
Great. So you said the message is that admit rather than treat as outpatient. Is this what you're trying to say as well? Don't take the risk of
symptoms. Yeah. If they have symptoms, they are usually congested, and getting rid of congestion is not something that's easy to achieve without complications, meaning fluid overload is difficult to manage as an outpatient, and that is your primary goal, and you're better off admitting them. You'll get better results quicker.
So as you said, it's like cooking heart failure. It takes a long time in children until they're symptomatic. So once they're symptomatic, it's going to be serious. Is this correct?
That's right. It takes several days to undo what has happened over months. You can't achieve it in 24, 48 hours. So you're looking at usually 5 to 7 days to establish even early treatment, and that's without any parenteral vasoactive drugs in children.
Second question, if you want to define heart failure and you're coding for the heart failure, what would you use? I mean, would you try to measure the BNP? I mean, you want to make sure, apart from clinical, you go clinical and lab, or how would you define heart failure in a child?
That's a difficult question. I'd harken back to the fact that you need to understand whether or not it's systolic or diastolic. You need to understand whether it's biventricular or left ventricular only. You need to understand whether it's associated with mechanical abnormalities, meaning structural disease of a valve or loading. And if it's purely myocardial, then you can start to deal with the fact that you can assess it and classify it according to both echocardiographic parameters, biomarkers, and symptoms, all three of those. So one single definition is really difficult to attain for a complex syndromal condition. And I would hesitate to offer you one sentence to summarize that.
In one of the papers that was shown, that one of the, I think it was in ERI, they said that BNP is one of their different parameters to define heart failure, the BNP number. We don't have this in children that well, is it? Do you do that routinely?
I think you're asking me, and yes, we do. More so in the United States than we did in Canada. There's very good data that will support the concept that BNP is a sensitive tool for identifying subclinical heart failure in multiple settings, and certainly correlates with symptoms in patients who do have clinical symptoms, whether it's in the emergency room, whether it's progressing towards mechanical support, or whether it's recovering from an acute episode with diuresis and other therapies. Yes, it is used, and yes, it is helpful for prognosis.
So to sum up here, so as we used to know from 15 years ago, heart failure is a clinical diagnosis. So you go for tachypnea, tachycardia, blood pressure, peripheral perfusion, hepatomegaly, ascites, whatever. And then plus the lab results that we go for pro-BNP and so on. And do you agree it stays as a clinical rather than lab, or take them both together to if you have the facilities? Is this correct?
I prefer a clinical diagnosis informed by lab tests as my approach. I know I'm a bit old-fashioned, but that's still the way I do it.
Okay, I think we'll stop with the questions, have a break for our participants. We go for our panelists, Dr. Najashi and Dr. Veltman. Do you have any questions to our panel, to our speakers?
Yeah, so my question will be to Arai. So thank you for the great speech. But there was during our webinar, there was one of our senior cardiologists who's asking, are we still considering the group of Fontan, back to Fontan? We are mixing them up. I mean, those right isomerism or isomerism syndrome, we are still, the heterotaxy, we are still comparing them to those patients who's having like normal ventricle function, normal AV valve. What's the fate? I mean, when we talk to the family, I mean, we know that Fontan, maybe they could go for a transplant, either a heart or heart and liver. What about isomerism? Where we are with them? I know it's a challenging question for all of us, but maybe we get your input in that.
Well, if I can start, and then I'll pass it off to the adult congenital experts, of which there are several here. I would say that the one thing that really scares us is seeing a patient with, as you said, heterotaxy, and specifically patients who are right isomers with poor pulmonary arteries, abnormal pulmonary veins, or significant AV valve dysfunction being proposed for single ventricle palliation. My personal feeling is that we're likely better off considering patients like that for transplant primarily. I know that that's controversial, but I've seen too many unfortunate children progress down a road of incomplete palliation and have numerous complications and then have no option whatsoever because of that. So to be honest, I'm not sure how many of these have made it to adult congenital care at this point. But we do have survivors with Fontan, with right atrial isomerism, not that many. And we certainly have survivors who've had transplantation for that.
So I would say I don't know that I've seen that many individuals in adulthood who have right atrial isomerism and a Fontan circulation. We are seeing more hypoplastic left heart syndrome patients with arriving in adulthood who've had a prior Fontan operation. They do seem to fail quite a lot earlier than those with a morphologic left ventricle. But I can't think of a case that I've had personally in an individual with right-sided isomerism.
I wonder if I can just contribute to this discussion as well. I would agree with particularly Paul with your comments about right isomerism. I think by the time they get to adulthood, and many of them of course don't get to adulthood area, and that's why we don't see so many of them. But they have so many complicated problems. For one, AVMs in the lungs, and as Paul mentioned, pulmonary arteries that are not good, pulmonary vein stenosis that are underdiagnosed, and also increased pulmonary vascular resistance very often. And that's not to speak then of the intracardiac problems. So really, even for transplantation, they pose quite a significant challenge. One of the considerations that we had for patients like this, if, for example, you take into account the end organ disease that comes along with all of this, which is really complex, is the question whether there's any way in which this patient can be resuscitated over time. And for example, can you deal with the AVMs in some way, either with interventional therapy or with some sort of medical therapy that's anti-proliferative? Alternatively, can you deal with some patients by doing some form of palliative redirection of a hepatic venous effluent? In other patients, you might be able to use VADs, or I know in some centers in the US, even total artificial hearts, in order to resuscitate the end organs of this patient, then possibly to become a transplant candidate. But as you can hear from this discussion, these patients are notoriously challenging, and I completely agree with the person who posed this question. It's a very complex group, and unfortunately, many of them will end up inadvertently with palliative care, actually, and don't even make it for transplantation. I want to just bring up another issue that we've been speaking about, which is the issue of, Ari, you mentioned this about dealing with hemodynamic issues in the single ventricle population, which obviously poses a lot of challenge to us. And we know that by the time Fontans end up in trouble with heart failure, many times we've almost missed the boat, when they come like that, and they're nutritionally deficient and so on. So the question then relates really to, let's say a patient has AV valve regurgitation, moderate or severe AV valve regurgitation, and a Fontan patient has not got overt heart failure symptoms. What do we do with that patient? What do you all do with those patients? Do we take them to surgery? Do we repair the valve? Do we replace the valve? Do we do nothing, wait for transplantation because, the risks? So I'd like to ask our panelists, their view about how do we deal with that. That's a prime example. Can we intervene with this hemodynamic situation or this hemodynamic problem before it ends up in heart failure or overt heart failure, shall I say?
I'll take the opportunity of speaking for children first, but I'll leave most of the time for Ari because he probably sees this more than we do. This is very, very program and surgeon dependent. There are programs that excel with 3D imaging, and I come from one of those where Jeff Smallhorn made it part of his mission in life was to train a number of people to do 3D valvular assessments on tricuspid valves in single ventricle patients. And occasionally the surgeons were persuaded to try and do an AV valve repair. I've seen the occasional prosthetic valve in the tricuspid position in a single ventricle. It is not a pretty sight, and it usually doesn't work very well for very long. So I'd strongly discourage that. I think for us, our approach to this is to look for patients who are progressing. If they are progressing, we will usually give them one chance at surgical repair. If that doesn't work, we will put them forward for transplantation automatically. So I'm keen to hear what happens in the adult arena, though.
Harry, what do you think?
Yeah, I mean, I have to say that my experience with hypoplasts is more limited because I think the ones that we have been seeing are the good ones, the ones that didn't have significant AV valve regurgitation, who I think end up failing probably before they get to my age group. I have seen people with a morphologic left ventricle who have significant AV valve regurgitation. And I think, though, that my thought process probably would apply to both. And it really depends, as Dr. Cantor was saying, on the surgeon and really my confidence in the surgeon's capacity to do a valve repair and to do it with sufficiently low risk that I'm not going to cause the patient harm or make them no longer basically close the door on possibly being a candidate for transplant by sending them for an additional procedure. And that I think that's going to vary from place to place and from patient to patient, where you really, and this is where the whole concept, I guess, that this is not something that's going to be able to be proven by data, where we're going to have to really just have consensus on an individualized basis for each given patient in each program. I do think that there's a role for it in individuals who are doing well otherwise and are sufficiently low risk. But I mean, the limited data out there suggests a substantial risk of mortality with AV valve repair in adults with the Fontan circulation. And so it's, you know, I always really debate with myself. And I can tell you the one patient that I've had who I really thought about this with, we presented and the decision was made to just kind of, he was doing okay, he was clinically stable, and the decision was made to just kind of let him go until he developed symptoms of failure and then list him for transplant.
Thanks, Eric. And the people might not know, but Dr. Najashi has actually a huge experience with Fontans at the Prince Sultan Hospital. Khalid, what's your take on it? You know, what do you guys do for AV valve regurg in this sort of setting?
The problem is that, as you are, aware of that they survive longer time before they become symptomatic. And then when the time they become symptomatic, it's very difficult to, convince a surgeon to take them. Usually their ventricle function become impaired. Mostly they are the unbalanced AVSD as a start. And then their valve repair is difficult. Unfortunately, we have lost, the eldest maybe was 38, 40-year-old. He was unfortunately accepted as a transplant candidate in the state, but he was admitted with a frank heart failure where he could not go out of the ICU. And then his liver deranged and his kidney deranged. So the team there who is accepting them in US, they said it cannot be pursued. But we have a good number where they really survive long and only in medical therapy. They did not go to surgery. I am aware of one patient who had been off-label use for a clip in the state as a bridge to transplant. Remarkably, he did very well till that AV valve regurg dropped from severe till mild. The patient will be coming back and he will be evaluated to see when when this clip going. So most of our really trend with them is to go conservative, because really most of the people, they will say, okay, if the ventricle function is good, we are not attempting valve repair because it is difficult. Just leave them till they reach the transplant limit. And unfortunately, it's not only for the AV valve, it's only for some of those who had a dilated route with aortic valve regurg. Most of these people think that maybe conservative approach till they reach the transplant. And I think, as I said, I think we need to treat them individualized.
Yeah, and I think it's very much.
You go for diaphragmatic valve dilation. What do you do? Sorry, Khalid, you said about the AV valve and then the semilunar valve. So the AV valve, you go for a clip if you can. But what would you do for the aorta? Dilated aorta.
Again, the aortic valve in the setting of a Fontan with a dilated route is really a very challenging. Even the result out there is only a case. A case reports with not really encouraging too much to convince a surgeon for a route and a valve in a setting of a Fontan. So these mostly they will go to conservative approach till they reach to a transplant stage.
What are others, other congenital, Dr. Feldman and Dr. Cedars? What do you think of the dilation of aortic root in Fontans?
Well, firstly, I think there's some subgroups where there is very significant aortic root dilation. And these patients actually often have aortic root dilation over a very long period of time. And I think some of them you can actually pick out patients that have had dilated roots of 5, 5.5, sometimes more in size, but have been absolutely static for 10, 15 years. And you might be very surprised at that. We also do know that the risk of rupture is not the same in patients who've had 2, 3 stenotomies as, for example, in patients with Marfan syndrome, for example. And the surgical scar and so on may be protective in each individual case. But I think there's some clear-cut indications for surgery. And I think if you see someone expanding over time very rapidly, that's certainly something for concern. And the second issue also is in a patient, obviously, with expansion and rapidly developing aortic regurgitation that's dilating the ventricle and affecting function. I think, as Paul says, if you've got a good surgeon to hand, this is something that you really could weigh up the pros and cons of going in for surgery. My personal view with the AV valve regurgitation is there are some valves that are very attractive to surgeons. And for example, in a double inlet left ventricle, if one of the AV valves is severely regurgitant, affecting ventricular function, making the ventricle dilated, and I think the Boston group have shown these big ventricles have very poor outcomes. If you close off one of those AV valves that's regurgitant, that's a really good option for some patients, and so I think important to look out for specific situations where that, where you could actually intervene and make a difference for patients. Rima, I wonder, do you mind if we shift gears? Because there were some questions from the audience that I just want to bring up, just one or two questions. Is that okay?
Sure. There's one question very interesting about the dexamethasone and COVID and other congenital heart disease. I don't know if you've seen that. The use of dexamethasone in COVID with congenital heart disease. Is it good or bad?
I see. I didn't see that question, but I wonder if anyone on the panel will speak to that issue. I must confess that I have no experience in order to comment on the benefit or lack of benefit thereof.
We haven't used it in Johns Hopkins to the best of my knowledge. I don't know if other people have used it. Certainly, I don't think in general, and specifically, I don't think we've used it in congenital heart disease patients.
But I think it's logical. I mean, it's not going to be of harm. Why are we worried about other congenital and dexamethasone? I mean, it's going to be, he's already a little bit immune compromised, and he's got COVID, he's got congenital heart disease. And so I think the implication will be the same, whether he is other congenital or no other congenital. The use of dexamethasone in this condition. Do anyone agree with me?
I think, Rima, the concern with the steroids in general has been that, in the earlier experience, actually the prognosis was worse if steroids were applied in COVID-19 infections. But I think as people gain experience with the cardiomyopathies and the myocardial dysfunction that arise de novo in COVID-19, I think there has been some positive experience with using both immunoglobulins and steroids in that setting. But I agree with that. I don't think there's enough data really at the moment to make any firm recommendations about that.
There was not enough data. I've read the Chinese data. It's not enough. Some say yes, some say no for DEXA. So it was equivocal, and so they just dropped it. But now everybody, even in the news, everybody's talking about DEXA and COVID, DEXA and COVID. So I think in our era now, in what's happening, we don't have a lot of medical data to support or not to support what's happening, except the Chinese experience. To my knowledge, I'm not sure.
Yeah, there's also some data from the United Kingdom now, actually, which is the one that supported the use of dexamethasone. May I ask, again, our panelists, just regarding anticoagulation and COVID-19 infections. Ari, you mentioned that, one of the key features of COVID-19 infection is thromboembolism and microthrombi. And I think we've all heard of the issues of intracardiac thrombus, pulmonary embolism, DVT, and you mentioned this sort of microemboli that may affect the myocardium. So, for our ACHD patients or congenital heart patients, should we anticoagulate all of them if they're admitted with COVID-19? Should we use full anticoagulation, thromboprophylaxis? Should they just be on aspirin? Let's again take the Fontan or the systemic right ventricle who's in heart failure, who's got COVID-19 infection coming in. What would your approaches and recommendations be for anticoagulation? Can we start again maybe with, or maybe let's start with Ari first, and Paul, I don't know what your approach is in the pediatric population, but let's hear from the adult point of view first, and then.
Yeah, that's a really great question, and it's a difficult one to answer because I can see an argument on either side of it, obviously. And I think that probably in the absence of other data, I would recommend the same thing that I would recommend in somebody who doesn't have a COVID infection. So if somebody otherwise merits anticoagulation as a result of their lesion or other cardiac comorbidities, then I would continue that. I don't know that I would initiate anticoagulation in somebody who presents with COVID, regardless of their underlying anatomy, unless there was something else to drive me to do so. So that would probably be my approach.
Okay.
In children, the biggest concern we have are outpatients who are shunt dependent, and particularly infants in the first 6 to 12 months of life, who are pending further palliation, dependent on a small gauge shunt for pulmonary blood flow typically. We've talked about it, and our decision has been at this point simply to continue on with aspirin and not to use anything more formal for these patients. This is partly because the actual logistics of managing formal systemic anticoagulation with Coumadin in a larger population or outpatients is challenging. And because we've not yet had any patients admitted who have had a shunt thrombosis as a result of COVID. We've had one patient who had what appears to be perinatal contact with an entire family with COVID who then had to undergo a complex repair of a transposition of the great arteries, which was a late diagnosis of the VSD. And this patient developed extensive thrombosis in the VADS, in the ECMO circuit, which was necessary because of a difficult initial postoperative course. And we speculate, and this is on full heparinization, we speculate that these patients are hypercoagulable even in the acute phase and even in children. So I would say that there is definitely a concern. We don't yet have a fixed protocol approach to this.
Thanks, Paul. And oh, sorry, Rima.
No, I was just saying there was a case in with the pulmonary embolism diagnosed, I think, in the military hospital in Riyadh. She came with a normal heart, but then they found pulmonary embolism in her, and that was a COVID positive. So they are hyperembolic or whatever, even without congenital heart disease. So if you have congenital heart disease on top, so probably it's more logical to anticoagulate. I'm not sure if I'm being so generous.
I mean, it is difficult. I share even a case with a Prof. Grosjean like 2 weeks ago. She's a Fontan who's a mother of a baby like 6-7 months. She was only in aspirin. She was tested positive. She remained asymptomatic. It was a challenge to bring her back to the hospital to start like a warfarin. Just we were discussing it together. I mean, she remained asymptomatic. She finished the 14 days. She had the test again. She's negative. She's doing very well. I know that I think anticoagulation maybe is, but then she was lucky. I mean, she did not have any symptom. It's difficult. I know it is difficult situation, but I'm not sure where we are with them, and especially those single ventricle who's really all, I mean, prone to thromboembolic phenomena.
I think the well patient with mild disease is perhaps a very difficult or a very different kettle of fish compared to the patient who's admitted, let's say, to ICU or to high care setting, and they have very, very high inflammatory responses. And as the inflammation is turned on, many of them have this hypercoagulable state as there's this close interaction between the clotting cascade and the inflammatory cascade. And so I think the current recommendations are that all inpatients at least should be on thromboprophylaxis, so on basically on once daily dosing. And patients that are high risk, and we can identify those patients, you know, maybe they've had a past history of clot, maybe they've got very poor ventricular function, maybe they've got an existing embolism or thrombus already. Clearly, those patients should be on anticoagulation. And patients that are already on anticoagulation, I think obviously it's important to maintain that. Similarly, patients that are maybe on dual antiplatelet therapies, you know, not to stop that at least, but to continue with that approach. One of the bit of evidence that comes out now is that patients with an apparent DIC sometimes paradoxically respond to anticoagulation. And the reason is that their coagulation system is obviously so activated that they literally consume platelet factors, and I think, coagulation factors. And I think there's some evidence now that if you anticoagulate those patients earlier on, maybe you can prevent some of that from happening.
Okay, can I have a question that goes to the pediatrics and probably also to the other congenital? The use of Entresto in heart failure, so the new medications, the Sacubitril and Valsartan combination in heart failure in children. Dr. Cantor's talked about the use of, well, I don't know the age group, but is it like your slides showed 1 year onward? So could you please elaborate on that?
Firstly, to comment that there's an ongoing clinical trial which has recently been unfortunately suspended in many countries because of COVID. It had enrolled close to target for patients over the age of 1, but very few patients under the age of 1. Based on preliminary data of biomarkers, the FDA has already decided to grant an indication for heart failure in biventricular physiology patients, in other words, not single ventricle patients, but patients with 2 ventricles, or anyone over the age of 1 with symptomatic heart failure. So there is already an existing FDA approval for use in children. It's obviously widely used in adults across the world already. So I think the only important thing for those who are considering converting a patient from an ACE inhibitor or an ARB drug is to be certain that you have allowed 36 hours of washout prior to starting Valsartan-Sacubitril, because the combination of these two drugs, an Enalapril or another ACE inhibitor and Valsartan-Sacubitril, can be lethal with angioedema. So it's an absolute indication to stop for 36 hours minimum before starting Valsartan-Sacubitril.
So just shift any patient or specific patients that you would try Enalapril or Captopril and then shift, or from day 0 say, okay, he's in heart failure, biventricular heart failure, instead of starting Enalapril or Captopril, I'll start Entresto. Is this the message, or there are hidden indications where would you go for Entresto as second line?
Firstly, you need a pediatric formulation to administer it to young children, and right now it's not clear that that is available in many countries. It has been used as part of the clinical trial, but sprinkles or solution or suspension are not widely available. So we're talking about older children who can take tablets. Yes, it is reasonable to start outpatient therapy with Valsartan-Sacubitril without going through an ACE inhibitor first.
Okay, great. Any more questions? I think we're running out of time. Any questions? Dr. Huda, we haven't heard you. Do you have any question? Any comment? My last question regarding the use of VAD prior to transplant, and Dr. Cedars said that it's not very common to use VAD in single ventricles. Okay, and well, I'm not sure, is it technically difficult, or are we going to improve that? Or because what we understand is that heart transplant, as you said, that Dr. Cedars, is going to be a long waiting list. So to improve the quality of life, do you think VADs or ventricular assists will help those single ventricles? Is it a technical issue, or it's a no, 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 there's no future for VADs in single ventricles? The same question goes for pediatric age group. Whilst in single ventricles, that I'm not sure that we list them that early, but also would you use VADs in Fontans and like say young adolescent or something like that prior to transplant?
So that's a good question. I think a lot of people have that question. There's very little data available. I think that the total combined Intermax and PDMax data for ventricular assist devices numbers in the low 50s. So that represents the totality of experience in the United States with this technology. I can understand why there's a lot of trepidation about using it in Fontan patients, because physiologically Fontan patients are substantially different than two ventricle patients. And a part of what we're trying to do, as we've alluded to, and Dr. Cantor specifically alluded to, a lot of Fontan patients fail predominantly due to the circulatory failure more than pump failure. And so when computer models have been used to look at the possible physiologic impact of VAD in Fontan patients, it's found that it actually may increase central venous pressures, which in somebody who's suffering typical Fontan failure actually may make them worse, technically. Now, anecdotally, people who have used VAD in Fontan patients say that this doesn't take place. We recently did an investigation of Fontan patients in the Action Learning Network, in which we looked at individuals who had a VAD and who had physiologic data from both before and after VAD implant. And it seems that there are kind of two categories of patients. There are some patients who do seem to get better with decreases in both Fontan and ventricular and diastolic pressures with VAD implant. And then there are some who seem to do worse. I would hypothesize that those who do worse may have more robust aortopulmonary collateral flow, and that basically when you apply the VAD, you end up not only loading the venous system, but you end up loading the ventricle, and that those individuals do worse. If we are more aggressive about aortopulmonary collateral coiling before VAD implant, would that make a difference in outcomes? Remains an open question. Right now, I think if you were to ask me what the optimal way to support somebody who has a Fontan circulation would be, I would say it has to depend on the mechanism of their failure. If they have systolic contractile dysfunction, or if they have normal transpulmonary gradient but evidence of diastolic dysfunction, I do think that there is potentially a role for a ventricular assist device in those patients. However, in patients who have evidence of either lymphatic failure or have elevated pulmonary vascular resistance, something combining cavopulmonary support with ventricular support or cavopulmonary support alone might be the way to go. Again, absence of any data, just my ideas.
Paul, do you agree to that? And what would you put VADs in Fontans? What age and what indication?
To be very honest, the practical limitations are very difficult here. We're talking about not only supporting the systemic circulation, but then having to deal with cyanosis as well, quite likely. And so you have two problems. Where do you cannulate the patient? How do you get enough venous flow? So you're talking usually about atrial cannulation. Potentially you don't have enough flow to actually circuit the VAD, so maybe you have to take down the Fontan. Then you have a situation where you need an oxygenator as well. These are very, very difficult situations, and most often we try not to do that. We try very hard to get patients who are failing Fontans supported with inotropic support as an inpatient and get them listed for transplant. Occasionally patients have tried using total artificial heart, but the technical and surgical limitations here are very substantial and hard to overcome in small body surface area individuals, i.e. patients under the age of 10. There really are very few options. In the Glen, we have a few more options. What we'll typically do is take down the Glen, put back a BT shunt to control flow to the lungs, and do an atrial cannulation strategy for a VAD in someone who's waiting for transplant already. This is only seen as a short-term bridge. It's typically using a Centromag device. We think we can get a few months out of that, and I've seen it done, and it works sometimes.
Thank you very much. Ari, in the last minute, you want to tell our viewers about the Action Learning Network, since something that we don't know much about, and maybe it could be of help to others?
Absolutely, and I think that the Action Learning Network is interested in expanding internationally, so we would definitely value interest from anyone in the world. What the Action Learning Network is a quality improvement network designed to improve perioperative outcomes after mechanical circulatory support. It initially was focused in pediatric patients, although it's now expanded to adult congenital patients. As I know all of you are aware, there was an incredibly high stroke rate, particularly with Berlin hearts for the pediatric patients. And that was the initial focus of the Action Learning Network, was to decrease that stroke rate through a combination of improving the homogenization of anticoagulation management, blood pressure management, and in-hospital communication and handoffs between providers and nursing staff. And just through the educational system that was established, a series of kind of guideline documents and entry of data in a longitudinal manner, the Action Learning Network has been able to decrease stroke rate in Berlin hearts by nearly 50%, and in continuous flow VADs by 30% for pediatric patients. And so what participation in the network entails is essentially entering information for your patients from your site into the network. You are then provided with feedback on your performance as compared to other centers, as well as educational documents with graphics displaying what the accepted protocols are for optimal management of pretty much every step of the mechanical circulatory support process. The network is now expanding to include heart failure in the pediatric population, as well as transplant in the pediatric population.
So how do people get access? They go to the website, or what?
Yeah, so that's right. Yeah, all of the protocols are, I believe, available, open to access on the Action Learning Network website, which I can share with you, and then you can also post on your website if you would like. And actual participation in the network right now it's not limited to US and Canadian sites, but those are for IRB purposes. We have not been able to really expand beyond the US and Canada at this point, but I think that is the future target, to have this be something that can really help improve outcomes for pediatric heart failure patients around the world. So we would very much value interest from anybody here. And I guess another thing that we could do if there's interest, please reach out to me. You're welcome to publicize my email address, and I'd be happy to forward your interest on to the Action Learning Network leadership for inclusion.
Lots of, the Saudi Heart website. There's also the Pan Arab website. There's lots of. We can put your email, and then I get from you what you want, and then we can post it to all those places, and then they can directly talk to you. Dr. Khalid, last thing. Since this is an educational event, what websites would you advocate for other colleagues to log into and learn from other congenital heart disease?
Oh, definitely. The ACHA, the Adult Congenital Heart Disease Association, is a very active one since years and years, and it is mostly a patient-derived one. Yes, there is a contribution from physician, but it's running for always. The problem is the material are in English, so it need an effort to translate it to the language of like to our language, to Arabic or to other language if needed. So I think what we need is, as a practitioner now, is that to encourage our patient, whom they are already, I mean, some of them, they have the access to, either they are themselves interested or they are having enough support so that they could really initiate their website. I think the initiative should come from patient, that they advocated something. We tried with some patient, but still it's not yet successful.
So Action Learning Network is for professionals, and other congenital heart disease network is both for patients and professionals. And Dr. Cantor, do you have any websites for heart failure and updates and stuff like that that people can share and learn, because our viewers are from different levels, different countries?
No, we're part of the Action Network as well. I would say that is by far the best resource for users of multiple levels at a clinician level, nursing level, and other professionals. It has a ton of resources, so I would suggest you go to that.
Thank you very much. Dr. Feldman, do you want to say anything before we conclude?
I'd like to just mention the International Society of Adult Congenital Heart Disease is still very active, and we've got a brand new website where people can pose clinical questions on, and so that will go live very shortly. Then I'd also like to encourage people to make use of there's an international registry now for COVID-19 infections in adult congenital heart disease. And Dr. Jamil Abulhossein is running that. We're part of that here from King Faisal, and I think Khalid also from Prince Sultan. So, but I think it'll be very important to accumulate data, worldwide data, so we can get the best out of our individual experiences with COVID-19 in our patients.
Can you say the name again of this, where you want people to participate with their information regarding COVID-19?
Yeah, so you're very welcome. People can contact me, but the main, the folk who actually started the project is Dr. Jamil Abulhossein. He's from UCLA, and the other person is Dr. Craig Broberg from Oregon, from Portland, Oregon. But if it's easier for people to contact me, I can certainly put them in touch with the study coordinator, who can then recruit them and recruit their patients. And the data is submitted via REDCap, so it's a really very straightforward way of doing it.
I think one of the beautiful things about COVID is that people are on the webinars and we're talking the same language, and we're really coming together in a very easy and cheap way. Please allow me to thank everyone, all our eminent international speakers, our eminent local panelists, our Saudi Heart staff, our head of the Heart Failure Society, everyone, and many, many thanks to the 2.3K registrations and people who really sort of had patience to listen to us. Thank you very much, and have a very good night or a good morning wherever you are. Thank you.
Thank you, everyone.
Thank you.
Night.
Thank you. Good night.